My name is Rachel Gill. This is my implementation teaching project for my clinical site of cardiac rehab at St. Luke's Hospital. I am working with a patient who was previously admitted. I will not go into specifics due to HIPAA, but the patient's name is Andre, and he has agreed to verbally be heard and interact with my presentation for him. So Andre, if you don't mind just giving me a yes that you agree to be audio recorded for my video.
Yes, I agree.
Thank you. Okay, so you were recently hospitalized here for some chest pain you described, and then you said that you were basically diagnosed with hypertension, right?
Yes.
Okay. So when you came in, this is all new to you?
Mm-hmm. Yes.
Okay. So you are now on some medications to help manage your hypertension, and you're going through the cardiac rehab program here. How much do you know about hypertension, would you say?
Oh, maybe 10%.
Okay. Well, that's not surprising because you are not in the healthcare field and this is new to you. So I have this presentation that I created with several sources from scholarly articles all the way from 1975 all the way to 2020. There's information in here from the CDC, the World Health Organization, along with several American medicine journals that you can find. I don't know if you're familiar with like EBSCOhost or anything like that for schools. No. We have to use a database to find our sources. We can't just Google it. Okay. We can use Google for some things, but in order to have access to articles, you have to, in journals, instead of paying for them, your school will allow you to view them if you go to school there and you have an account.
Okay.
So that was a mandatory thing for this, and those are all cited at the end of the presentation. So you are now working on managing your hypertension. Let me see if it'll go. There we go. So a major problem in achieving better control of hypertension is based on the fact that hypertension is a silent, asymptomatic disease oftentimes. There are other times that you can have symptoms, and some symptoms that you can feel and see are flushing, a lot of the times headache. What's another one? Dizziness and blurry vision is also a sign of symptomatic hypertension. The face flushing is a big one. So when you notice that and you feel very hot and you maybe have a headache, it may be a good idea to check your blood pressure to see what it is. So ignorance of the general population as the nature of elevated blood pressure, its morbid effects, and the methods of maintaining its control is widespread and contributes to a large percentage of undetected and untreated hypertensive subjects in the United States. And just so you know, we're talking about the United States as a whole, not the world. There are some things in here that'll mention like India or other countries, but this in general is about the United States. It is suggested that community screening programs combined with simplified diagnostic evaluation, intense patient education, such as what I'm doing right now, and a follow-up with your primary care provider may greatly increase the percentages under continuous treatment and control of those with hypertension. So what they mean here, that community screening programs, so like when you go and get your blood, when you don't go and donate blood, you have to have a set of vitals done. I don't believe you can have your blood given if your blood pressure is over 180. That might have changed since the last time I got my blood done, but you see my point. So patient education, again, what I'm doing here, and then screening programs also includes cardiac rehab. Like we monitor your blood pressure frequently before, after, and even during your workouts at times. Okay, so in this presentation, we're going to be focusing on a lot of things. I'm just going to try and not to make it like 2 hours long. But we're gonna focus on hypertension demographics. So who it affects, the race, gender, age group, etc. Incidence and prevalence rates, so some statistics. Societal concerns, so like the United States as a whole. Epidemiology, so what is the disease, where did it originate, what exactly is it, and what happens in the body when you do have high blood pressure. Implementation is how we implement treating hypertension. And then there's a few other things in there, and then just a simple conclusion at the end. So hypertension demographics, who does it affect? Anyone and everyone. Just because I'm a white female does not exempt me from being diagnosed with hypertension down the road. It affects all races. However, there's a statistic out there that has been shown that African Americans have the highest rates and percentage rates of hypertension. Americans over the age of 40. Now, that's not saying only Americans over the age of 40. There are several young people who have been diagnosed with hypertension under the age of 40. That does not exclude children either, based on certain diseases that they may have. Men and women. It affects both men and women. It doesn't matter. Lower income groups. So what I mean by that is people who don't necessarily have insurance. People who don't necessarily have the money to pay for their medications. They have more other priorities to live. Rural subsidies. So what I mean by that is this is a big, Maumee is a subsidy of Toledo. Mm-hmm. So Napoleon, Ohio would be like a rural subsidy of Maumee and Toledo. Yeah. So that is because there are less resources. So you usually will have to travel to a larger city, therefore a larger hospital, to get to the resources that you need for your diseases. And then educational level is another big thing. A lot of people don't know, when they need to go to see a doctor. They don't necessarily know that they need to have a physical every year. And that's usually high school or below. So incidence and prevalence. Oh no. Whoops. Sorry about that. So incidence and prevalence rates. So trends in hypertension prevalence in the United States have generally been obtained from a survey called the National Health and Nutrition Examination Survey. I've been calling it NHANES because that's a big mouthful. But that is what it is abbreviated with. So NHANES is a sequential, stratified, multi-stage probability sample of the non-institutionalized U.S. population. It was first conducted in 1960 to 1962, and then the latest, and by latest I mean before 2000. It has been used since in 1999 and 2000. The definition of hypertension has also changed over that period. So what is your definition of hypertension right now?
Just elevated blood pressure?
Correct.
Yes.
Now, when that is the basic definition of it. There are some other things we will get into as well that also define hypertension that go along with describing it as high blood pressure. So then what exactly is hypertension if the definition of it changes over time, right? So hypertension is now defined as a condition in which the force of blood against your arterial walls is too high. It's defined as blood pressure above 140/90, which is where you tend to sit, correct?
Yes.
Okay. And it is considered severe if it is anything above 180. Now, there are two different numbers, your systolic number, which is your top number, and then your diastolic number, which is your bottom number. We will get into that later. Mm-hmm. So higher blood pressure equals a higher risk for heart disease, heart attack, that's supposed to say stroke, I don't know why it says store, and death. So did you know that about hypertension? Did you know that it increases your untreated increases your risk for these?
No, not before this happened.
Okay. So blood pressure, again, it's kind of going along with what this is the force exerted by circulating blood in your heart against the walls of the body's arteries, the major blood vessels in the body. Again, hypertension is when the blood pressure is too high. Cannot stress that enough. Some people think it's low blood pressure. Some people don't even think it has to do with your blood pressure at all. Blood pressure is written as two numbers. Systolic, which represents the pressure in your blood vessels when the heart is contracting, okay? And then the diastolic number is the pressure in the vessels when the heart rests between your beats, okay?
Okay.
So today, you were concerned that your diastolic number was a little high, correct?
Yes.
So that means that the pressure in your vessels when your heart is resting is high. Now, that doesn't necessarily mean it's a problem. It could be your body continually adjusting to your medications as well.
Okay.
And that is not something that happens instantly. It can take a while for your body to adjust. And a lot of people will wax and wane, meaning they will be in the normal range, or they will be in the high range, or their diastolic will be low, their systolic will be low as well, vice versa.
Okay.
So back to this NHANES thing. The National Health and Nutritional Examination Survey is a program of studies that is designed to assess the health and nutritional status of adults and children in the United States. So where does hypertension play into this? So the survey is unique in that it combines interviews and physical examinations. So when you get a physical, a blood pressure is included in that. It's a major program of the National Center for Health Statistics. That is part of the Centers for Disease Control and Prevention, and has the responsibility for producing vital and health statistics for the nation yearly. Have you heard of Healthy People 2020?
No.
So I'll encourage you to, if you feel so needed, there's Healthy People 2020, Healthy People 2010. They do it every 10 years, an evaluation of the United States population. I said yearly, I meant every 10 years, excuse me. So the NHANES interview includes demographic, socioeconomic, dietary, and health-related questions. The examination the examination component consists of medical, dental, physiological measurements, as well as lab tests, so blood work, administered by a trained medical professional, whether it be a nurse, a lab tech, a doctor, etc. Findings from that kind of survey are used to determine the prevalence of major diseases and risk factors in the United States. So they take all that data from those surveys that are filled out in different areas of the United States, and they average it out. Diseases that can be tracked by the survey, this is just a few of them, include diabetes, heart disease, hearing loss, kidney disease, other infectious diseases. COVID-19 is actually one that's being tracked right now. Of course, it is everywhere. And then hypertension, of course. Back to disease prevalence in the United States. So around 3 million Americans are diagnosed with hypertension each year. Okay?
Mm-hmm.
So that is equivalent to about 1 to every 2 American adults have hypertension. That's literally 50%.
Yeah.
The statistic, I believe, is literally put at 45 to 50%.
Wow.
Did you know that?
No.
Okay. So 21 million adults, I figured I'd put it in numbers versus percentage points. 21 million adults are recommended to control their hypertension with lifestyle modifications only. 87 million adults are recommended prescription medication as well as lifestyle modifications. So that's kind of where you fall in.
Mm-hmm.
You're taking some medications to help manage it, as well as making lifestyle modifications. So what do you think is a lifestyle modification?
More physical activity, focusing on your diet, possibly meditation.
Yes,
So,
exactly.
like that.
Perfect. Most adults with hypertension in the United States do not have their hypertension under control. And that is a scary thing, because going back to the whole cardiovascular disease, stroke, and heart attacks are the leading causes of death in the United States, and hypertension can lead to all of those. 31 million adults in the United States are already treated with hypertension medication may need their current medication dosage that they're taking increased or to be prescribed additional medications to achieve control. This is not uncommon. Usually, so in your case, you may a little down the road need to be put on a different blood pressure medication or another type of, or they may need to take one away. Does that make sense?
Yes.
Okay. So this is a little diagram I found in regards to the prevalence and treatment control among the U.S. So right here, remember when I said 45 to 50%? That's what this is showing. So about 108 million people.
Wow.
Lifestyle modifications only is contributing. This says 19%. My source says, 21%. And then lifestyle modifications plus medication includes about 81 to 87%, otherwise known as 87 million people. Blood pressure control status. So around 21 million people are uncontrolled. And then you go into these little, where is this at? Sorry, I'm trying to remember how to read this. It was a little complicated. But you can see a small percentage have it controlled. And then blood pressure treatment status, about 51% or 31 million adults have it treated. 49% have it untreated. Otherwise, 30 million people. That's a lot of people when you think about it. Because in the United States, people as a whole, there's about 300 million people. And then if you take the adults into that, that's literally about half the population, if not a little more, maybe less. That's a huge percentage of adults when you think about it. So, and this goes back to the whole people with blood pressure greater than or equal to blood pressure 140 over 90, that's greater than or equal to that. So why is hypertension an important issue in low and middle income countries? The prevalence of hypertension varies in the World Health Organization, regions and country income groups. The World Health Organization African region has the highest prevalence of hypertension, which is 27%, while the World Health Organization, I should have just wrote that out, region of the Americas has the lowest prevalence of hypertension. So we are one of the countries that has it the most controlled, according to the World Health Organization. Review of current trends shows that the number of adults with hypertension have increased from 594 million in 1975 to 1.3 billion in 2015. So that is, 40 years? That's 40 years.
Yeah.
That's how much it's jumped.
Wow.
Adults in the United States. And I threw that in there because that's just such a big number. With an increase largely seen in low and middle class income countries. And that doesn't just go for countries, that also goes with low income families, low income societies as well. This increase is due to mainly a rise in hypertension risk factors in those populations. So what do you think are some risk factors for hypertension?
Oh, diet, obviously, depending on what they eat, physical activity, stress levels.
So like a sedentary lifestyle, diet high in cholesterol, high in fat, and salt. That's another big thing is salt. Cut back on your salt intake. So hypertension in your society. So about 50% of people in modern societies have blood pressure sufficiently elevated to result in increased mortality. So mortality means death rate, basically. This proportion, is much smaller in undisrupted societies of hunter-gatherers. So what they mean by that is people who literally live off the land.
Right.
In most cases, the elevated blood pressure in modern society, so us, is associated with physiological changes and characteristics of chronic stress. The difference between blood pressure in modern populations and that in undisrupted hunter-gatherer societies cannot be accounted for by genetic differences or in salt consumption. So by what they mean by genetic differences, sorry, I'm losing my train of thought. Hypertension can be genetic. It can be hereditary. Now, not saying that hunter-gatherers can't have it, because they can.
Mm-hmm.
They are less likely because of their diet. Have you heard of the paleo diet?
Yes.
That is what a lot of their diet consists of, that and vegan and vegetarian, which all of those diets have been proven to be whole foods. So a lot less salt, a lot less fat, a lot less cholesterol in those. Two primary features of modern society which contribute to the elevation of blood pressure are community disruption and increased work pressure, so stress. Drug therapy and relaxation therapies for hypertension attempt to counteract the physiological effects of social stress. So what they mean by that, like recreational marijuana use, meditation, relaxation therapies, massages, anything to reduce your stress level, because a stress level can have a huge impact on your blood pressure. However, it's more appropriate to use the occurrence of hypertension as an indicator of fundamental social problems which need to be solved. So, the epidemiology. So, how did hypertension come about? Hypertension develops over time and is not a communicable disease, meaning you cannot pass it from person to person. There are 3 different levels of disease prevention for any kind of disease. There's primary, secondary, and tertiary. So, let me get to my little paper here. Primary prevention, you stop the disease before it starts. So this is kind of like those people who notice their blood pressure was high and they're recommended to make lifestyle changes with no medication. It's a combination of lifestyle changes. Secondary prevention, early detection and management. So kind of where you're sitting, okay? So you were having the chest pain, you came to the hospital, we ran a bunch of tests and did some screening. Found out you had high blood pressure. So now we are working on preventing your disease from getting worse, possibly making it better.
Mm-hmm.
And then tertiary prevention is management of advanced disease. So you're not going to get any better. However, we can prevent it from getting worse, therefore improving your quality of life. So some risk factors for hypertension are related to who you are as a person. You can't help getting older. You can't help where you come from. You can't help if you're male or female. You can't help your family's history. Risk factors that are modifiable include, like you mentioned, getting rid of living that sedentary lifestyle, getting rid of that sedentary lifestyle, improving your diet, especially diets that are high in sodium. Obesity, alcohol consumption can contribute to high blood pressure. Sleep apnea kind of goes along with obesity, and when you fall asleep, you stop breathing. That's what that is. So when that happens, your blood pressure can rise due to stress on your body, and that's not good, and strain on your heart. High cholesterol. So there's 2 different kinds of cholesterols, the HDL and LDL that we've talked about before. You can control that and lower those. Diabetes is a huge thing with it. That's why you see some of our patients here, we check their blood sugar as well. Smoking plays a huge part, because when you smoke tobacco, it constricts all your blood vessels, and it can even cause damage. And then your stress level, of course. When you're stressed, you're very tense. All your blood vessels are tight. It makes it harder for the blood to get through there. Therefore, your heart is working harder to get the blood where it needs to go. So some resolutions. It kind of goes back to, let me see if I can go back. I don't know how to go back in PowerPoint. It kind of goes back to what I said before, but this also includes cutting back on caffeine. Caffeine, drinking coffee, energy drinks, things that are high in sugar, raise your blood pressure immensely. Stopping drug use, so like narcotic use, as in like heroin, cocaine, methamphetamines, those kind of things. You want to increase your exercise, which is what we do here. And then kind of like what Mark told you today, when you exercise over time, like he said, for 24 to 48 hours, It can keep your blood pressure managed, and that is what we want.
Okay.
Weight loss, of course, it puts less strain on your body, less strain on your heart, and it can help clear up your arteries, believe it or not. Manage your stress levels, of course, and then your dietary modifications. So I want you to come up with 2 goals, a short-term goal and a long-term goal. Short-term goals are goals that can be achieved in an appropriate, timely manner that can be measured and observed. So let's say less than a year. Let's say 6 months. A long-term goal is something you wish to do in the future that's the exact same thing of a short-term goal, but longer. So let's say in a year. So that could be like a change in weight loss or a diet change. Do you want your cholesterol to be lower? Where do you want to be in 6 months? Let's say for a short-term goal.
Short-term goal. I want to lose a minimum of 30 pounds.
Okay.
So to get to my target weight, in my mind, is 180 pounds.
Okay.
Cholesterol right now is 181. I would
Mm-hmm.
like to manage that within the next 6 months, and
Okay.
potentially drop that to close to a normal level.
Perfect.
So
How do you think that goal can be measured? The weight loss, how can it be measured?
well, obviously,
Mm-hmm.
scale,
Mm-hmm.
and basically as far as weight loss, well, and BMI.
Yes, that's another big one.
So
And then your clothing size.
yes,
And then you can also, believe it or not, look at your cholesterol levels. That is also an indication of weight loss. However, not in all cases.
right.
So a long-term goal, same thing.
Yeah. Long-term goal is to be able to keep the weight at my goal weight.
Okay.
Become more physically active.
Okay.
Potentially, walk, run in a marathon.
Mm-hmm. Okay, that's a
Something
great
like
goal.
that. So.
That's a great goal. So, I was going somewhere with this. Hold on. I literally had somewhere where I was going with this. You threw me off with the marathon running. So, you want to be at your 180 pound goal.
Yes.
That, again, is measured by weight loss. Now, you remember when we talked in your interview about healthy weight loss versus unhealthy weight loss.
Right.
Healthy weight loss is anywhere from 1 to 2 pounds a week.
Right.
Okay? And both of those goals are obtainable. So cardiac rehab, where you are right now, hanging with all your friends.
Right.
So cardiac rehab is not just offered here. It's a program that is offered in multiple hospitals for qualifying patients after a significant cardiac event. So those kind of a cardiac event includes a heart attack and an MI. Those are 2 different things. Sudden cardiac death, meaning it's kind of like an MI, but your heart completely stops. And you can do CPR. You can get yourself back with doing CPR. Sometimes you can't, unfortunately. Heart failure and all of the effects that come with that. You do not have heart failure, so that does not really apply to you.
Well, that's good.
And then coronary artery disease, and there are a few others as well, but those are the pretty significant ones. So cardiac rehab utilizes a team of cardiac nurses such as Brandy, Kate, and Diane. I myself am a cardiac nurse as well, but I don't work down here. An exercise physiologist, so Mark and Mackenzie, to encourage, guide, and measure improvement and success in patients who have had a significant cardiac event. So what we do with that, we do your exercise. We check your heart rate and your heart rhythm to prevent you from going into a lethal rhythm, because believe it or not, significant strenuous exercise can put your heart into a lethal rhythm at times. Not in all cases, so don't worry. We measure your blood pressure, like I said before, after, and sometimes during your workouts and between workouts. We also measure blood sugar in diabetics, and the reason we do that is because we want to know what their fasting blood sugar is if they ate in the morning, because blood sugars can drop with exercise. So during your time here, kind of like what we mentioned, you'll be wearing a heart monitor so staff can monitor your heart rate and rhythm at all times. You will have your blood pressure taken periodically before, during, and after workouts. We track your weight as well to see your progress. Glucose monitoring for diabetic patients, and education is huge, kind of like what I'm doing with you right now, which I greatly appreciate. So back to the whole education thing, a lot of people have different views on what hypertension is and is not. And a lot of them, when you ask previous patients about it, are not always correct. And a lot of this kind of stuff can be very confusing to people who are not trained on it. So that's why we want you to basically become a professional in your management of your disease. So, do you have any questions for me right now?
No, I do not.
Perfect. Okay.
Yeah.
So, we kind of answered a lot of questions during the presentation, I feel.
Yep.
Okay. Now, we have a short quiz. I am not going to film you during the quiz.
Okay.
I am just going to have you put your answers, and I will take a picture of it to upload to my instructor.
Okay.
Is that okay?
Yes.
All right, perfect. There's that for you. Here is a pen, and I'm going to end this